afternoon, everyone. We welcome Dr. Carys Lippiatt. She is a consultant clinical scientist in biochemistry and the clinical lead for specialist laboratory medicine, including toxicology and trace elements at Leeds Teaching Hospitals, NHS Trust. She is a fellow of the Royal College of Pathologists and a registered member of the Health Professions Council for Clinical Scientists. Her main interests are biochemical markers of toxicity, lead toxicity in infants and childhood, technical and clinical validation of novel biomarkers, and their translation into clinical use in patient pathways. Her focus is on the appropriate use of clinical laboratory services to ensure the best possible patient outcomes.
Thank you. Thank you so much for your kind introduction, and thank you so much for inviting me here to your conference. It's the first time for me to visit the Middle East, and I've been blown away by your hospitality. Thank you very much. So today I'm going to talk about real-life experience from a toxicology laboratory in Leeds in the UK. And my remit today is to tell you the definition and role of a toxicology laboratory, go through the basic requirements for a toxicology laboratory, specific requirements, and then discuss some of the challenges that we've encountered in the toxicology laboratory at Leeds. So if you look on the internet, if you look in textbooks, there are lots of different definitions of toxicology, but I found one that really resonates with me and what I believe that my role in toxicology is. So this definition states that toxicology is the use of analytical procedures to isolate, detect, identify, and quantify drugs and other xenobiotics, which are chemical substances foreign to animal life, to help in the diagnosis, treatment, prognosis, and prevention of poisoning. There are probably two well-recognized forms of toxicology laboratory, and they are all involved in looking at toxic effects, looking at metabolism of chemicals, looking at drug-drug interactions, age-related effects. So what's the effect of a xenobiotic on a newborn baby, on an unborn baby, on an infant, on an adolescent, on a childbearing age lady, or on elderly patients? What are the analytical limitations of laboratory investigations? And what are the clinical limitations of people who are looking after patients who have been exposed to a toxin, and the clinical limitations of knowledge within the laboratory? All of those things need to be considered. And the two main types of toxicology laboratory are forensic laboratories and clinical laboratories. And some laboratories offer a forensic and a clinical service. But in the main, forensic toxicology is the application of toxicology for the medical or legal investigation of death by analysis of body fluids, plants, fabric, hair, drug paraphernalia, etc. Whereas in a clinical laboratory, the focus is really on the analysis of drugs and chemicals in body fluids for the purpose of patient care. So these are probably looking a little bit more at the basic requirements of toxicology laboratories and how they differ between a forensic and a clinical laboratory. In a toxicology laboratory, the chain of custody is really important. It's absolutely critical that if a sample is taken from somebody at post-mortem, that you document when that sample was collected, where it was collected, who collected it, and what was the identity of the person that the sample was collected from. And at every point that that sample is transferred from one person to another, one location to another, if anything is done to that sample, it's opened, an aliquot is taken, analysis is done. Each step is documented in the chain of custody form. In the clinical toxicology laboratory, there is no requirement for a chain of custody, but of course you will have an audit trail from the moment a sample is requested in the electronic patient request system or on a piece of paper on a request form, when that sample is booked into your laboratory information system, when results are added to that sample, when a report is issued, you will have that sort of audit trail. In terms of accreditation, there is more stringent accreditation required in a forensic toxicology laboratory. But the clinical laboratory is usually, as any other routine clinical laboratory, accredited to ISO 15189. For forensic work in the UK, you need a Home Office license, but for clinical toxicology laboratories, you don't need that. And what a Home Office license mandates is that you have very secure premises, you have safes to store any toxicological drugs, etc. And there are very stringent inspections of the premises to make sure that they have the right security. So next, I'll talk a little bit more about the basic requirements for a clinical toxicology laboratory. So one of the things you do need to consider is, even if you are working in a clinical laboratory, there is also likely to be some interface with forensic services. So when you consider a patient who's presented with poisoning or suspected poisoning, what are the circumstances of that poisoning? Is it accidental? Is it intentional? Has there been a medical or therapeutic error? Is it recreational misuse? Has there been an adverse reaction to an agent? Is there any malicious potential? Is there any potential of mass exposure? Is it a population exposure or individual exposure? So in some of those circumstances, you may need to consider that there may be a legal aspect to what you were doing, and your reports or your results may actually be presented in a court of law. What's the route of poisoning? Ingestion, inhalation, skin contact, etc. They need to be considered. And what's the location of poisoning? Is it poisoning in the home? Was the exposure in a prison, in a care home, in an area of work? All of those things might mean that ultimately there may be a forensic need to submit your results or your reports. And so even in a clinical laboratory, it's important that you have a secure, safe cabinet, and only certain individuals will be able to access that cabinet, and there will be an audit of when things are put into that cabinet or taken out of that cabinet. You also probably need a good auditable frozen storage system. So any pediatric urine samples that we receive in the laboratory, we store for 6 months, and we have an auditable record of that storage. So looking at, clinically, what does a toxicology laboratory need to provide? These two papers, although they're relatively old now, 2006 and 2009, they're good reviews of the management of patients presenting to hospital with acute poisoning. And funnily enough, both papers actually conclude the same thing, that ultimately the management of the critically poisoned patient centres on careful supportive care, not on fancy diagnostics. And the two most important and valuable tests for poisoned patients are actually the 12-lead ECG and a paracetamol measurement. But do we need to offer anything else? We probably do, otherwise I wouldn't be standing here in front of you all today. So how can we find out what else we need to do? The USA National Poisons Data System provides a report every year, and the UK NPIS also provides a report every year of the inquiries that they have had from hospital locations about poisoning. And they both have these things in common. In adults, the commonest poisoning agent, if you like, and the most inquiries were about analgesics, followed by household cleaning substances, antidepressants, cosmetics, and then antihistamines. In children under 5, that's slightly different, so there's more exposure to household cleaning substances, followed by analgesics, cosmetics, dietary substances, and foreign bodies. In unborn babies, there's always a concern about teratogenic substances, drugs that are usually given inappropriately to the pregnant woman. And, the NPIS report does confirm that the top agent that their consultants received referrals for in 2022 to 23 was paracetamol. But second to that, an unknown agent, so someone who's presented with the features of poisoning, but the agent isn't known. So as a laboratory, we can help in those circumstances. And we have two main roles. I would argue that the first is the confirmation of diagnosis when it's not clear. And secondly, we can also aid patient management plans. So we can advise and provide information to the clinician to direct treatment with antidotes or identify patients that would benefit from specifically directed medical treatment, such as hemodialysis, hemofiltration, charcoal, etc. We can also offer further investigations for management of those patients, and we can also offer results that can aid decisions about stopping treatment, stepping down from ICU, etc. And actually, the basic requirement in terms of repertoire and supportive tests for a toxicology laboratory are tests that should be available in every laboratory where you have inpatient management. And these tests need to be in local laboratories, they need to be provided 24/7, 366 or 65 days per year, depending on whether it's a leap year, and you need to provide a rapid turnaround time. And these are your standard biochemistry tests, if you like, and the standard calculations. And probably in terms of toxicology, if I can find the pointer. There we are. Probably the most important ones really are anion gap and osmolar gap, for example, in the evaluation of a patient who's suspected of having ingested toxic alcohols. But in terms of diagnostic tests for toxicology, many of these are also tests that are available in routine laboratories and should be available locally 24/7 with a rapid turnaround time. So obviously sorry, it's premature. So what I've mentioned already, paracetamol, if we need to measure paracetamol 4 hours after it's been ingested in an acute exposure, and that will help using the nomogram on the far right here to guide treatment with N-acetylcysteine. Iron should be measured as soon as possible at 4 hours and 6 hours post-exposure to guide treatment with desferrioxamine, which is shown here, complexes iron for safe excretion out of the body. Digoxin to guide treatment with Digifab, and we must always remember that the half-life of digoxin Digifab complexes in the circulation is about 16 to 20 hours. So for 3 to 4 days following giving Digifab to patients, the digoxin assay is not valid. You shouldn't re-measure digoxin until you know that the Digifab digoxin complexes have been cleared from the circulation. And that will be an even longer period of time in patients with renal impairment. We can also measure lithium, theophylline, many of the therapeutic drugs can be associated with toxicity, and we need to be able to provide measurement of those in serum samples. Also, methemoglobin, when patients are suspected of being exposed to aromatic compounds to guide treatment with methylene blue, carbon monoxide poisoning that can be treated with hyperbaric oxygen, salicylate, ethanol, even TFTs for thyroxine overdose, and arguably in some laboratories, valproate and possibly paraquat. Although obviously that's banned in many countries, it's still manufactured in the UK, so there may also be a need for that sort of analysis. But what about specific requirements for a toxicology laboratory, which is usually a regional lab rather than a local laboratory? So there are several things to consider. Infrastructure, what repertoire of tests you need to provide, what instrumentation you might be able to obtain and what you need. How do you recruit your staff? What type of staff do you need? What are the quality measurements for a toxicology lab? And what guidance is there out there for best practice? So infrastructure, this is obviously quite important because a patient can present with poisoning or suspected poisoning anywhere in the country, but you're not going to have a toxicology laboratory everywhere. So where's your centre of clinical expertise? In the UK, we have the National Poisons Information Centre, which I referred to previously, and they have a system called ToxBase, which is an online repository of information about the toxicology of anything you can imagine, just about. And if it's not on their website, if you phone them up, then they can certainly give you more information than anybody else could in the UK, I would conjecture. They're available on the phone, they have web pages, there is an app, and they're available 24/7. They have consultants who are on call covering the UK, and the main centre is in Birmingham, which is located here, so basically in the middle of England, but they also have subsidiary centres in Edinburgh, Newcastle, and Cardiff. So you can see that in Leeds, we're not near Birmingham, we're not near Newcastle, we're way in between, and so we rely on the NPIS when we have a clinical emergency in terms of toxicology. In terms of analytical expertise, there are several forensic labs, and they probably have the widest repertoire of tests. They have many super specialist assays, and they have lots of technical expertise. Regional hospital laboratories like our lab in Leeds, we have many specialist assays, we have some technical and clinical expertise, and then a step down from that is your local hospital laboratory. So they'll have the basic repertoire that I described earlier. They'll be open 24/7, and they need to have robust referral processes. So we need to communicate very well with those laboratories that might feed samples into our lab. They need to know when we're available, when they can send samples, and they need to know their processes out of hours or within hours, how to make samples safe, and how to get them to us in a timely fashion, and that we got all the information we need to provide them with the results that they need and when they need them. There may also, of course, be point of care for toxicology. So there are plenty of urine dipstick tests now for drugs that can be used in the emergency department, and the laboratory needs to provide oversight and governance of that testing as well. What about logistics? So as I said, the patient could present anywhere in the UK, and the samples will be collected locally from the patient. But those samples need to be delivered to the toxicology laboratory. So when do they need to be delivered? Where exactly do they need to be delivered? Because hospital laboratories are quite big, and we've got probably 5 different laboratory sites within our hospitals, and 2 hospital sites. So it's important that if you provide the right information to your referral hospitals. Also, how will they get the results? Do you know who to phone for the results, or will the lab phone those results out if they're abnormal? Do they get electrically transmitted? Is there an email report from PDF, or do you have LIMS links with those laboratories? All of those things need to be considered. And your IT links, you know, how good are your IT links with your toxicology laboratory? There may not be any IT links. So communication is really key when you're setting up a toxicology laboratory, and communication is key for the running of that toxicology laboratory, so that you're providing the service that other laboratories need from you. So what repertoire do you need? So you probably, in terms of toxicology, there are 4 main categories of toxic agents that you might need to measure. Heavy metals such as lead, arsenic, and mercury to guide chelation therapy, and for that you would need an ICP-MS mass spectrometer in the main. Toxic alcohol such as ethylene glycol and methanol to guide fomepizole or dialysis treatment, and that can be done using GC mass spec in the main. Pesticides, organophosphatase, and carbamates, you would need to provide cholinesterase activity assays, and that can guide atropine therapy, and it can give you an indication of whether it's acute or chronic poisoning. And they're usually spectrophotometric, HPLC, and enzyme tests. For drug misuse or drug overdose, you need to be able to provide a comprehensive drug screen, and this will help in the diagnosis of unexplained coma if you don't know what the drug of exposure is. And usually they can be done using immunoassay and or mass spectrometry. So that instrumentation is really important to consider. In Leeds, we actually have, we do have an ICP-MS for trace metals, and we have mass spectrometry for our urine drug assays. But we don't offer cholinesterase measurement, and we don't measure toxic alcohols. And people are often surprised that we don't measure toxic alcohols because they're probably something that we get lots of phone calls out of hours at weekends from someone in the ED phoning to say, I've got a patient, we think they've drunk ethylene glycol, can you give us an urgent result? And we always say, no, we can't give you an urgent result. Collect the sample now, make it safe, and we can send it to a referral laboratory. Sometimes we can send it out of hours if the referral laboratory is open and has the staff available to run that analysis, but otherwise it can wait until Monday morning. If your index of suspicion is high, if the history is good and convincing, and if you've got an anion gap, an osmolar gap, then go ahead and treat the patient. We've got the sample, we will know what their ethylene glycol or methanol concentration is when that sample is analysed. But in the main, the advice is to treat that patient, usually with fomepizole, and take repeat samples after 24 hours and another 24 hours, and continue treatment until the result is undetectable. So what do you need to consider in terms of your equipment? It's not just the cost, but it's also, you know, how convinced are you that, or how reassured you are that the manufacturer has appropriate engineer numbers to support you with that piece of kit? How available are the engineers? What's their response time? You know, if you call in that your ICP-MS is down and they say, oh, well, we'll see you next week, is that good enough? It probably isn't. If they need to send you parts, how quickly can the courier get the parts to you? And how easy is it to get those parts cleared through customs? What's your analyzer lifespan? And if you only have one analyzer, then what's your contingency? The other thing, and probably the most important thing you need to consider really, is your staff is the laboratory's most important asset. You need staff with technical expertise, clinical knowledge, and experience, but you can't build that from scratch. So you might rely on other laboratories or other clinical centres to help you train your staff, to provide proper competency assessment of your staff, and you need to provide continuous professional development. When you have experienced staff coming up for retirement, you need to know that you've got good succession planning in place. And sometimes the only way you can really look after your staff is by making sure that you're part of a network of toxicology labs who will all have the same challenges. So you pool your resources. What are the requirements in terms of quality? Well, it's not just accreditation, as I'm sure you all recognise. Yes, of course, we need to provide the right test at the right time. The most important thing is to collect the right sample at the right time. You need appropriate request escalation. You need to have someone who is available out of hours to say, well, yes, we can maybe offer that analysis urgently, it's clinically indicated, or actually it's safe to leave that. We'll make the sample safe and we'll analyse it tomorrow morning. You need to validate and verify your methods. You need to obviously perform QC and EQA, and you also need to consider the appropriateness of your interpretive test comments. It's important to audit your service, seek feedback from the clinical users about the patients that you've analysed samples on, and again, important to be part of a network. There are two main publications that are good guidance for toxicology laboratory services. The first is by Bob Flanagan. He published this in 2004, and then a publication in the Annals of Clinical Biochemistry, which was a network consensus. And I think they're due for review, and I'm part of the Clinical Toxicology Network in the UK, and we hope that we will be able to publish an update of these guidance later this year. But as you know, these things always take longer than you expect. So what challenges might you encounter in the toxicology laboratory? I think I might have a few minutes left. 6. Okay, good, thank you. So this is actually something that's been very challenging in our laboratory and didn't really involve the toxicology lab at all, per se. Involved the clinical scientists, but not necessarily the laboratory. So recently, nitrous oxide abuse has been on the increase in the UK, mostly amongst students and young adults who don't use alcohol. It's very cheap. You can buy it in balloons from taxi drivers, usually, I've been told, and the evidence for this often is these little silver-coloured canisters in parking lots and on the curbside. So our ED doctors had identified that there were several patients over the years, or over the months, sorry, presenting with peripheral paresthesia, ataxia, bladder, bowel control changes, abdominal pain, some with peripheral neuropathy, leg weakness. Some had lost the ability to walk without crutches, and it was very worrying. And until you got, a similar history from a large number of these patients, it was difficult to determine what the cause was. And lots of these, teenagers and young adults were embarrassed and didn't want to admit that they had been using nitrous oxide. So it's also called laughing gas, and it gives you a sense of euphoria, of otherworldness, and the story in Leeds and other cities in the UK really is that although it's used medicinally as an anaesthetic and it's used in the food industry as an aerosol propellant for whipping cream, it's also quite common in student parties and in teenagers and young adults as a form of recreational misuse as an alternative to alcohol. And it's actually the second most misused illicit drug in the UK, and it was classified as a Class C drug last year. So nitrous oxide irreversibly oxidizes cobalt-1 to cobalt-3, and that causes functional vitamin B12 deficiency. B12 is a cofactor for methionine synthetase, which is needed for the production of myelin. And so if you have functional B12 deficiency, you can develop myeloneuropathy, which can range from mild damage of peripheral nerves to severe subacute combined degeneration of the spinal cord, which is visible on MRI. We performed an audit, and in 2022, there were 12 patients who presented to A&E in Leeds with these symptoms. Vitamin B12 wasn't always low. 5 out of 12 patients had low vitamin B12, but homocysteine was raised in all of them. The reference range for homocysteine in our laboratory is less than 18 micromoles per litre, but all of these 12 patients had raised homocysteine between 56 and 200, and that's illustrated by this graph over here. The treatment is high-dose intramuscular vitamin B12, but it can take a long time for patients to recover, and in 9 of those patients, they already had subacute degeneration of the spinal cord, and 5 out of the 12 patients have needed long-term physiotherapy and occupational therapy to ensure that they can walk, support themselves, to stand. It really has had a huge impact on their lives. Some other challenges that we've encountered. So the pandemic was an incredibly challenging time for our laboratory, in the main because, our staff were sick and so they couldn't come into work, and we also had to restrict the number of staff that were in the laboratory at any given time. And so this provided us with huge challenges, because there might be some days where we didn't have staff to run the ICP-MS in particular, or didn't have staff to run some of the mass spectrometry assays. And what that has shown me really is that, yes, of course, you need to very, very carefully consider which tests which samples you need to prioritize clinically. So you may have a request for urgent drug of abuse screen or an urgent blood lead analysis, but you might not have all the staff needed to run those tests that day. So which do you delay, and which considerations can you use to make those decisions? And also, if you really can't run any of those assays and you need to refer elsewhere, then you need to know that you've got a referral laboratory lined up, that they've got the capacity and the capability to do the analysis that you need them to do on the day that you need them to do it. And so what happened, as a result of these challenges is we realized the importance of our business continuity plans, the importance of our contingency plans, and the importance of having good documented procedures for getting in touch with referral laboratories, and to make sure that we organize any referral of samples or any vetting of requests in an effective way when we're under these sorts of challenges. This argon, this is to remind me of the time when we actually ran out of argon. So our ICP-MS laboratory relies on a big tank of argon that's just outside the trace elements lab, and every 3 weeks we get a delivery of argon. But if the weather is bad, then the delivery driver might not come when they're expected. And so we actually ran out of argon one occasion last winter. And the other enemy to us really in the ICP-MS lab is that the senior technician who runs the ICP-MS lab, he is extremely organized and he is extremely efficient. And he loves having a clean slate at the end of the day. So if there's any work, he will try and get through it. But if you're running out of argon, then that is not what you need. Basically, we realized that we really need to keep an eye on how much argon we've got left. So after 2 weeks, we start monitoring how much argon we're using on a daily basis, just in case the driver isn't able to turn up. And we joke about it, but it is a real thing. So the gas delivery to our hospital has failed 3 times over the past 12 months. So it is really important that we monitor how much argon we've got left, and when we're getting down to critical values, that we don't run the routine analysis, we don't run the nutritional copper, zinc, selenium measurement. We wait until we've got a delivery so that we know if an urgent blood lead or mercury request comes in, that we can deal with that request.
Doctor, we run out of time.
Oh, okay, sorry. So I'll just briefly mention the Oasis drink bottle. So this is interesting because one of the pediatric nurses hand-delivered this bottle to us in the laboratory and said, "Can you measure this for drugs?" And actually we said, well, let's find out some more information. In the end, we said no, and this bottle was submitted to the police as evidence because the conjecture was that one of the pediatric patients had been poisoned by a drug that had been placed in the drink bottle. So in those circumstances, it's very important that you identify that as a forensic request. You can make the sample safe, but it shouldn't be analyzed. So I'll stop my talk there, but just to say thank you very much to you for listening, and also thank you to all of the staff at Leeds Toxicology Lab, without whom I wouldn't have anything to talk about today. Thank you.
Thank you, Dr. Carys. We're honored to introduce Dr. Ahmed Elshatory. Dr. Ahmed is a senior registrar in the Kuwait Poison Control Center. He has a PhD in clinical toxicology and an associate professor in Cairo University School of Medicine, Egypt.
Hi, everybody. I'm happy for having me here today. I'm going talking today about bridging gap between lab and ER clinical cases. As being a clinical toxicologist, and I have been working since 2004, and I'm currently working as a senior registrar in KPCC, Kuwait Poison Control Center. I'm going to approach my lecture today from a toxicological point of view. I'm going to give you examples of real cases based on our practice in KPCC in toxicological emergencies. First of all, do you think, is there a gap between the lab and the ER? Do you think that? Yes or no? If yes, I'll complete the lecture. If no, I'll complete the lecture too, to convince you at the end that this is yes answer. Yes, there is a gap. Do we need to bridge this gap? Yes or no? Yes, yes. Why do we need to bridge this gap? In order to improve the quality of the healthcare provided to the patient, we need our tools, like taking good history, do a proper clinical examination, and to have a toxicological assays that enable us to reach a final diagnosis or at least a differential diagnosis in order to formulate a plan and to monitor the response of our treatment in any case of toxicological emergencies. Okay? Our agenda, introduction, laboratory assays that should be available for the management of poisoned patients. I'm going to give examples of toxic alcohols, methanol poisoning, KPCC-based experience clinical cases. If I have more time, I wish I'll give you another example about carbon monoxide poisoning, KPCC experience clinical cases. Acute poisoning is a common reason for presentation and admission to hospital. Laboratory assays for toxins and or their metabolites are very important part of the management of patients with potentially serious poisoning. There is evidence that laboratory toxicological investigations are overused by medical staff. Do you agree with this? Yes. We have statistics, we have a database in KPCC demonstrating the overuse of toxic screens. For example, patient, 52 years old, he presented with abdominal pain. Patient admitted that he is drinking alcohol. Patient admitted to the medical ward. The medical staff sent toxic screen to check for ETG, for ethanol, whatever. Patient admitted that he's taking ethanol. Why I'm going to send this? No value. And many cases like this. Another example, cases of paracetamol. When we manage cases of paracetamol, usually we give the treatment NAC therapy, N-acetylcysteine, and the protocol is 21-hour protocol. And according to the evidence-based medicine and our guidelines, we have to repeat the paracetamol level before the end of protocol by 2 hours. Many clinicians started to do the paracetamol level while the patient is receiving the treatment every like 4 or 6 hours until the end of the protocol. This is overuse of laboratory toxicological investigations by medical staff. We have a lot of examples based on our experience over the last 2 years. There is evidence that the availability of these investigations varies between hospitals, particularly when required outside normal working hours. This may present problem in management, particularly as many poison patients present during the night or at weekends. What is the indication for toxicological laboratory assays? To confirm the diagnosis of a poison when this is in doubt, to influence patient management, like asking for further investigations. If a patient poisoned with paracetamol, okay, I did the level after 4 hours from the ingestion, levels come high, so EST is high, so after that I'm going to ask for a creat. If EST is normal, I'm not going to ask for creat. A lot of examples like this, and giving the antidote. It depends upon the paracetamol level, or taking the decision for hemodialysis or any means of extracorporeal methods, like in cases of methanol intoxication, and cessation of treatment as well. And to plan the reinstitution of chronic therapy, like patient taking digoxin, patient presented with chronic digoxin toxicity. We give him, like, for example, the Digifab antidote, or manage the patient symptomatically. And we are just monitoring the level until it becomes therapeutics to decide when to reinitiate the chronic therapy of the patient. Many cases like valproate, carbamazepine, we do the same for reinitiation of the chronic therapy. For medical, legal, or forensic reasons, it's outside our scope here. So at the end, it's a balance between the best practice investigations to ask for the investigations in favor of the patient management, and at the same time to avoid the unnecessary investigation, to listen, to reduce the cost, okay? Laboratory assays that should be available for the management of poisoned patients are, this is accordingly National Poison Information Service, UK, in cooperation with the Association of Clinical Biochemists. This classification, they classified it to group 1. It says that should be available on a 24-hour basis in all acute hospital managing acute toxicological emergencies. And group 2, that not necessary, it's called specialist or infrequent assays, not necessary to be available directly, but arrangement should be in place to be accessed urgently. And it is the responsibility of each individual hospital to ensure that appropriate arrangements are in place. And the staff can follow this arrangement, including outside normal working hours. Laboratory staff should have contact details readily available for specialist laboratories providing these assays, together with information on how samples should be collected and transported. Another form of investigations, so called supportive investigations. Supportive investigation should be available on a 24-hour basis, should be available at least as quickly as group 1, turnaround time maybe 1 or 2 hours. This is group 1 assay that should be available on a 24-hour basis, like carboxyhemoglobin, digoxin, ethanol, iron, lithium, methemoglobin, paracetamol, paraquat, the qualitative urine test, salicylate, syphilin, and valproate. This is accordingly an NPIS. Group 2, which is called a specialist or infrequent, like arsenic, carbamazepine, cholinesterase, cyanide, ethylene glycol, lead, mercury, methanol, methotrexate, paraquat, and so on. Actually, in Kuwait Poison Control Center, we have our proposal. Do we need to follow this? Yes or no? To some extent, depending on what? Data, statistics, demographics. When I say to you, like, methanol should be transformed, I know it's not working. Methanol should be transformed from group 2 to group 1 based in KPCC experience. It means that we encountered a lot of cases of methanol, and we need to shift it from group 2 to group 1. It's not holy words. And like carbamazepine should be present in group 1, should be available 24 hours and turnaround time maybe 1 or 2 hours, because we have seen a lot of cases of carbamazepine in Kuwait Poison Control Center, okay? There is another form of investigation, supportive investigations, like full blood count, electrolyte, liver function test, INR, bilirubin, anion gap, plasma osmolality, osmolar gap, okay? I'm going to just give you real cases from our practice concerning the carboxyhemoglobin rule in management of carbon monoxide poisoning, and ethanol, methanol, plasma osmolarity, and anion gap rule in the management of toxic alcohol ingestion in Kuwait Poison Control Center. I'm not going to talk about ethylene glycol, which is not common. We haven't encountered any case of ethylene glycol. It's not available in our database, but methanol, we have a lot of cases. Just yesterday, I managed 2 cases of methanol overdose, okay? Toxic alcohol, methanol poisoning, KPCC experience, rule of laboratory investigations, ethanol as a group 1, methanol level as a group 2, measured osmolarity, osmolar gap, and the anion gap as a supportive investigations in the management of methanol poisoning, Kuwait Poison Control Center, KPCC-based experience. I don't think we have a cardiologist here. Mitral regurgitation, okay? How we diagnose mitral regurgitation? By the murmur, right? It's high-pitched, blowing, hollow, systolic murmur. How am I going to diagnose it? Based on, as a cardiologist, based on my clinical experience. What tools will help me in that? Stethoscope. It needs a skilled cardiologist to pick up this murmur. But I can have another tool that will aid me, like echo, which is easier. Diagnosing mitral regurgitation with echo or diagnosing it with stethoscope, for sure with echo, okay? If the mitral regurgitation is combined with aortic stenosis, there is another murmur, ejection systolic murmur with pre-systolic accentuation, plus the high-pitched blowing hollow systolic murmur. If I'm going to depend on my clinical skills only and my stethoscope only, it will be difficult. It needs a highly skilled clinician. But by echo, it will be like a piece of cake. This is the same idea as using the supportive investigation in managing such cases using the measured osmolarity, osmolar gap, anion gap. Imagine this is like the stethoscope only, and using the group 1 like ethanol and group 2 like methanol to diagnose a cases and to manage a cases of toxic alcohol ingestion, methanol ingestion. Just a rapid review of the methanol and what is the problem coming from methanol. Methanol is metabolized to formaldehyde by enzyme called alcohol dehydrogenase. Formaldehyde then to formic acid by aldehyde dehydrogenase. Formic acid, this is the non-ionized form, will be to the ionized form. And then to formate. Formate by L8 of folate will be metabolized to CO2 and H2O. Clinically, methanol as the parent molecule, it's not a significant toxicity. Okay, just will cause some CNS depression, but not like ethanol. May cause abdominal pain. But the main problem here, if we have a methanol level as a group 2 that we would like in KBCC proposal, we are going to shift it from group 2 to group 1 to help us. We need methanol level. This will be perfect if we have it. It will help me in the management. You will see in the cases that I'm going to tell you now how this will affect our management dramatically. What about ethanol level? Will it make a difference? Yes, for sure. And routine lab supportive like osmolar gap. Concerning the formic acid, we are expecting this acid, strong acid. We are suspecting anion gap metabolic acidosis, so we need ABG and calculate anion gap. So imagine this is ABG, anion gap, osmolar gap is my stethoscope. And the methanol level, ethanol level is the echo. So which one will help me more? But I still can depend on, based on my clinical experience. But as a clinical toxicologist, but we are talking now about ER doctors managing cases, not involved in clinical toxicology like a clinical toxicologist, okay? What is the treatment? Fumipizuli, which is costly. One vial, I think equal like $1,000. We'll block this enzyme, and this fumipizuli is overused by medical staff. And you will see the examples next few slides. Sodium bicarb will transform formic acid to formate. Then we can give folinic acid. This is treatment regimen. Will stimulate formate to CO2. And at the end, we use hemodialysis. Many cases of suspected toxic alcohol ingestion went through hemodialysis without need. You are jeopardizing the patient for the risk of the machine. You are consuming resources for what? For the absence of just a simple laboratory assay like ethanol here. Okay? This is the relationship between the osmolar gap and the anion gap. At the beginning, the methanol is the parent molecule, is osmotically active, so we are expecting osmolar gap to be high. And when methanol is transformed to formic acid, this will lead to decrease in the osmolar gap and the increase in the anion gap. So this is like our stethoscope. We interpreted case like this. If I find a patient with toxic alcohol ingestion with high osmolar gap, it doesn't, and he is normal, no metabolic acidosis, it does not mean this is not methanol. And if we find a patient with high metabolic acidosis, high 9 gap metabolic acidosis, with normal osmolar gap, it does not exclude toxic alcohol ingestion, okay? Before we go to our cases, just ethanol. Concentration is usually not required in patients who have ingested ethanol unless there is doubt about the diagnosis. Ethanol concentration should be measured urgently in undiagnosed coma, wide osmolar gap, suspected severe ethanol poisoning in children with unexplained acidosis for monitoring of ethanol use. If we are going to use it as an antidote, actually we have fumizole as alternatively ethanol. We are not using ethanol anymore in management of toxic alcohol ingestion. What about methanol? Urgent measurement of plasma methanol may be essential for the optimum management. It is reasonable to restrict the use in patients with a history of substantial methanol ingestion if the patient with severe toxicity as evidenced by metabolic acidosis in presence of high anion gap with or without increased osmolar gap. And we depend on the methanol to stop the treatment of fumipizole or even the hemodialysis, okay? What about the osmolar gap? Osmolar gap, range of osmolar gap is wide, from -14 to +10. So I don't have my baseline osmolar gap. You don't have your baseline osmolar gap. My osmolar gap may be -5. For you, maybe 5, okay? So can I depend upon it? This is the osmolar gap equation. Usually in our management plan sent to the ER, we ask for osmolar gap just to measure osmolarity minus the calculated osmolarity. And the equation here, we have to incorporate ethanol level, which is not available at the moment, okay? So maybe present early in the stage of poisoning. Due to the normal variability of osmolar gap between patient, toxic concentration may be present without osmolar gap being greater than normal. My baseline is -5. I tested and I became like 5. So it means there is 10 increase in my osmolar gap. It seems to you that it's normal, but it's not normal. This is increased osmolar gap is consistent with poisoning, but normal gap does not exclude it. I'll start with the first case, case number 1. I'm telling you that this is real cases based on our management in KPCC. This is a 45-year-old, previously healthy male brought to Al Amiri Hospital unconscious. Patient was found unconscious by his friend after drinking alcohol at a party 4 hours beforehand. Pulse 80, blood pressure 110/70, respiratory rate 12, oxygen saturation maintained on room air. Review of system negative except as above. Physical examination unremarkable, but decreased level of consciousness. Routine lab sent including measured, we asked for measured osmolarity. VBG was in normal limit. The ER doctor calculated the osmolar gap. He calculated the osmolar gap based on measured osmolarity 360 minus 2 by sodium plus urea plus glucose, and this osmolar gap is 79 millismol per kg. It's high. What does it mean? For ER doctor, the first thing comes into his mind, it's toxic alcohol ingestion. This is a conversation happened between me as a representative of KPCC and the ER doctor. ER, osmolar gap is high. I'm suspecting a methanol toxicity. This is, can I give the patient fumipizole? And is the patient indicated for hemodialysis? He's right, he's thinking right. Osmolar gap high, so I have to give fumipizole, which one vial equal $1,000. I'm going to give the patient like for 5 days at least fumipizole, a lot of expenses. And I think the patient is indicated for hemodialysis. Would like to wash out this osmotically active substance which is present in his blood. He's suspecting toxic alcohol. He's right. KPCC, fortunately, ethanol level was available at this only period of time. The kit was available at this time. We was running the ethanol level at Amiri Hospital at this time. And I asked for ethanol level. Ethanol level came 350 mg per DL. Please, doctor, hold the idea of fumipizole and hemodialysis. I'm going to calculate the osmol gap based on the ethanol level. Based on ethanol level, when ethanol level incorporated inside the equation, the osmol gap came 2.9. It means that this large osmol gap is due to mainly ethanol. So, let me have your thoughts. Is ethanol level beneficial here in this patient? Sure, because ethanol, high level of ethanol, we manage it just supportive measures, except after patient in coma or level of more than 500, we can in some patient ask for hemodialysis. And actually we don't give fumibazole at all. So we reduce the cost of fumibazole. We avoid the use of hemodialysis just because the ethanol level was available. So I think, do you think fumibazole and hemodialysis are indicated in this patient? No. And why? Because it's just ethanol intoxication. By the way, this patient woke up after maybe 6 hours. He's completely asymptomatic, vitally stable, VPG normal, and he signed lama and left. And he was drinking alcohol in one of the embassies. He's not, he's foreigner. Nothing done for him, just observation. Because at this time, and the only time we had the ethanol level, it was this case. Let's have another case. A 42-year-old male, known type 2 diabetes mellitus, alcoholic, present to LED, unconscious, coma scale 3, dilated pupil, patient intubated, and RPS 21, and was negative blood ketone. Osmol gap is 98 milliosmol per kg, and the anion gap was 18.6. Look at the first VBG. This is the numbers. Patient seen by ED, transferred to ICU. ICU decided for admission. We got the call from ICU. ICU, I need the dosage regimen for fumibazole during CRRT. It means that they decided to do CRRT 100%, and they give him the first dose of fumibazole, and you'd like to know the regimen of the dose during the CRRT, different from the usual regimen or the same. KPCC, I asked what treatment given to the patient and what was the initial VBG. The initial VBG was not catastrophic. And based on my stethoscope and my clinical experience, I'm suspecting it's not methanol. Or at least no need to rush for hemodialysis or to give fumibazole at the moment. I advised him, he said to me, just to give him 500 normal saline, first dose of fumibazole. We are preparing for CRRT. Decision has been undertaken. We are preparing for CRRT. KPCC, did you try fluid trial? Just according to our protocol and our regimen, we do like step 1, step 2, step 3 in management of such cases, based on our clinical experience and our stethoscope. ICU. He said, after discussion with our consultant, he was like telling me, don't waste my time. After discussion with our consultant, we decided to go for CRRT. Doctor, osmolar gap is 98, and anion gap is 18. KPCC, osmolar gap may be elevated due to methanol or ethanol. I tried to convince him. He's not convinced. Ethanol level not available. So, we'll go for CRRT definitely. Khalas, he decided. Unfortunately, ethanol level was not available. If ethanol level, from my experience, was available, and we measure it and incorporated in the osmolar gap equation, I am sure that the increase in the osmolar gap will be mainly due to this ethanol. The second VBG taken 2 hours after the start of CRRT, which is normal. In methanol intoxication, if it's methanol, at least I need to run the machine for like 18 hours to have some improvement. It means that this patient mostly ethanol, but I failed to convince the ICU to withhold such CRT and giving fumibazole. Why? Ethanol not available. Simple test. So it's a gap, right? It's a gap. And we need to bridge. Case number 3, 34-year-old male, past medical history of note, known alcoholic, brought to an ER after head trauma due to fight with his friend. Patient arrived drowsy and denied alcohol ingestion over the last 2 days. He's not telling the truth, by the way. Vitals within normal limit, examination unremarkable, routine lab sent, and osmolar gap, like it was 46, anion gap was 29. Al-E doctor consulted KPCC. He is concerned about the following VBG, and he asked about the same, giving fomepizole and nephrology consultation. Fortunately, the ER doctor had a rotation in our center in KPCC. He saw what we are doing. He has some trust in our plans, so he listened to me. But this VBG, if you look at it, pH is 7.1, acidosis. Lactate is 20, base excess is minus 22. Based on our clinical experience and interpretation of the supportive measures using my stethoscope, it's not methanol. This is the measured osmolarity. It was 333, and the calculated osmolar gap was 46. KPCC plan, fluid trial over 30 minutes, and could you please repeat VBG after 1 hour? No need now for fomepizole or hemodialysis at the moment. For me, I'm not sure. It could be, mixed ethanol and ethanol, I don't know. So if I try step 1 and it failed, I'm going to try step 2. If it failed, okay, I'm going to assume it's methanol. Look at this. 2 hours after the fluid trial, look at the improvement. Like 6 hours after the fluid trial, without giving fomepizole, without doing hemodialysis, patient is completely normal. I swear here it's ethanol, definitely. But I cannot prove. How can I prove? By the level. Okay? Carbon monoxide poisoning, KPCC-based experience, another example. But it's a good example for the effect of, because carboxyhemoglobin is available, okay? Carbon monoxide, it's called the silent killer. It's a colorless, odorless, tasteless gas and slightly less dense than air. And its common source is carbon monoxide is the partial combustion of carbon-containing compounds. In KPCC, we have a lot of cases of carbon monoxide. I'll show you now the statistics of this. But what's the problem of carbon monoxide? Carbon monoxide will bind to hemoglobin, will shift oxygen to a dissociation curve to the left, and this will cause tissue hypoxia. Brain will be affected. Heart will be affected by the hypoxia. I'm expecting patient to have CNS manifestation, cardiac manifestations. Carbon monoxide will bind to the myoglobin. In severe cases, will lead to atraumatic myoglobinemia or myoglobinuria and renal failure, and may affect the cytochrome oxidase, leading to anaerobic metabolism and increase in the lactate. This is a clinical picture in brief of carbon monoxide. What investigations do we need? We need carboxy hemoglobin level, but should be in the machine with co-oximetry, not all the machine. So when we give the plan, we focus on please do the sample machine with co-oximetry to show the carboxy hemoglobin level. What is the treatment given for carbon monoxide cases? Oxygen and HPO, hyperbaric oxygen. The level of carboxy hemoglobin is very important for us to take the decision to transfer the patient to the hyperbaric oxygen therapy in Jahra. We have an agreement with Jahra Hospital for transferring the patient for hyperbaric oxygen therapy. The idea of giving hyperbaric oxygen therapy to prevent the delayed neurological manifestations, which is not just to treat the patient, because oxygen will reduce the carboxyhemoglobin level within 6 hours. It's okay. But the idea of hyperbaric oxygen, according to the evidence-based medicine and tertiary literature, is to decrease the delayed neurological manifestations like Parkinsonism, cognitive disorders, and something like that. This is CO poisoning and HPO KPCC statistics. Over 2 winters, we received a total case of 146. 89 of them were candidate for hyperbaric oxygen. Based on what? What is the indication? The indication, solely we can depend on carboxyhemoglobin more than 25, even the patient asymptomatic. Just the level. In pregnancy, 15. Other parameters and other indications, neurological manifestations like coma, convulsion, ataxia, syncope,
Ahmed?
and so on.
I'm sorry, your time is up. Your time is up.
Type, okay, just 2 minutes.
Okay.
Just I'll show you one case. This is from our database, how we deal with, in general, in toxicological cases. طبعا this is patient information, caller information, toxicology information, what is the exposure, what therapy given. This case, this patient presented with exposure to carbon monoxide, and carbon monoxide level was 37%. Only if the patient asymptomatic, I'll transfer to Al-Jahra for HPO. But besides this, he was confused and comatose, so he was indicated for hyperbaric oxygen therapy. This is our plan. Patient improved. Case number 2, it depends only about clinical manifestations. Even carboxyhemoglobin level was less than 25, but still the clinical assessment of the patient is very important to take the decision in the management of this patient. Thank you.
We welcome Dr. Carys again.
So my second talk this afternoon is about the laboratory testing for prescription opioids and pregabalin abuse. And I've been asked to talk about the biochemistry of opioids, the clinical uses of opioids, the biochemistry of pregabalin, the clinical uses of pregabalin, and a little bit about laboratory testing for opioids and pregabalin. So the terminology, is it opiates, is it opioids? We quite often get request forms saying, please test for opioids, please test for opiates, and there is a little bit of confusion. Opiates are naturally occurring alkaloids, those that are extracted or harvested from the opium poppy, whereas opioids include opiates, and the term opioids covers both the natural chemicals from the opium poppy, also the substances that contain opiates, and also synthetic drugs with similar properties, and they all interact with opioid receptors. So what about the biochemistry of opioids? The pharmaceutical effects of the opium poppy have been known since at least 3,400 before Common Era, when it was known by the Sumerians as the joy plant. Opioids all act on endogenous G protein-coupled opioid receptors, of which the most important is the mu receptor, also the delta receptor, the kappa receptor, and the peptide nociceptin receptor. The action of opioids on the receptor is antagonized by naloxone, and opioid receptors are located mainly in the brain and the spinal cord. They are involved in ascending and descending pain pathways, and also in brain regions involved in control of emotion and reward, and brain regions involved in motility, cough, and temperature control. So opioids can be classified in terms of whether they are natural, semi-synthetic, or synthetic, but probably the most important or the most useful way of classifying them is probably according to their chemical structure. So the natural opioids, of which contain morphine, codeine, thebaine, and the semi-synthetic opioids, including the illegal form of diamorphine known as heroin, hydromorphone, dihydrocodone, dihydrocodeine, buprenorphine, oxycodone. They all have a common morphine ring structure, which is termed the 4,5-epoxymorphinium ring. Synthetic opioids are rather different, so fentanyl, alfentanil, and all of those fentanyl analogues that are too many to list in this table, they have a phenylpyridine structure, and methadone is different again, methadone has a diphenylheptamine structure. And the diagram on the right-hand side shows you a poppy seed roll, which is a very common way of increasing your blood and urine thebaine concentrations, and the various structures. So showing you the 4,5-epoxymorphinium ring and the phenylpyridine structure of fentanyl and its analogues, and in the middle here, methadone, its diphenylheptamine structure. And they all interact with the mu opioid receptor as their primary target. So what are the clinical uses of opioids? I'm sure it's not news to you that opioids are the most potent analgesic. There's good evidence of efficacy for the management of acute pain, for example, trauma patients, post-surgery patients, and also patients at the end of life. There's lack of evidence of efficacy for opioid treatment in managing chronic pain and long-term pain, although some individuals with chronic pain may obtain pain relief with intermittent use. It's difficult to identify those patients unless you trial them with the medication. Other uses are antitussive. You can buy codeine Linctus over the counter in the UK as cough medicine. You can also buy loperamide as an anti-diarrheal treatment. And there's lots of different ways of taking morphine. You can have a syringe for morphine on demand in certain clinical situations. There are transdermal patches for opiates. There are obviously oral tablets, and there are Linctus. And there are single doses or multiple dose slow release applications. Sorry. The converse of this, obviously, and something that really does need to be appreciated, is that there's a high risk of harm with the use of opioids. There are side effects which are unpleasant: constipation, nausea, vomiting, ranging all the way through to respiratory depression and coma. The phenomenon of tolerance is well known with opioid medications, and with long-term use, patients typically need higher doses to obtain the same amount of pain relief. There's a risk of dependence and addiction, and in the US in particular, it's really been termed an opioid crisis due to the number of people with opioid use disorder. And the risks in terms of diversion is that patients who are prescribed opiates for pain might divert their prescription to others, might sell their medication on the black market, etc. The risk of harm is greatest in patients with chronic non-cancer pain. The risk is highest in patients who have a previous history of substance abuse, and also higher in patients who have been prescribed 5 days or more of opiates. And so very careful consideration and vigilance is needed when you're making prescribing decisions about opioids. So what's the treatment for opioid misuse? Well, funnily enough, it's opioids, but certain types of opioids. So opioid agonist treatment is the prescription of lower potency opioids in a controlled way to allow dose tapering and safe withdrawal from the opioid that is being misused. And typically these are usually buprenorphine, which is given sublingually as an implant or as an extended release injection, or methadone, which is given as a Linctus or as a tablet. And these are only effective if the particular opioid is used exactly as prescribed. What about pregabalin? Why am I talking about pregabalin when I've just been talking about opioids? Pregabalin is an alkylated analog of GABA-aminobutyric acid. It was designed in the 1980s by a scientist called Robert Silverman in the States in a chemical search for a GABA-like molecule. And the aim of that research group was to develop an anti-epileptic drug which would act on GABA A and GABA B receptors to maintain inhibitory tone and rebalance neuronal excitation in individuals with seizure disorders. However, experiments looking at GABA, gabapentin, and a similar drug developed for the same purposes, called so gabapentin and pregabalin, sorry, is that they do not bind the GABA A and GABA B receptor, and in fact they bind the alpha 2 delta 1 and alpha 2 delta 2 subunits of voltage-dependent calcium channels in presynaptic neurons. And it's been found that they not only have anti-epileptic efficacy, but they're also effective against neuropathic pain, although the mechanism isn't fully understood. So the clinical uses of pregabalin. Yes, it's anti-epileptic and it's licensed for use as adjuvant therapy for partial onset or focal seizures at doses of 150 to 600 milligrams per day. It's also approved in the UK and Europe for the treatment of generalized anxiety disorder at similar and slightly lower doses. For the past 10 to 15 years, it's been increasingly prescribed for neuropathic pain. It's also available in slow release and extended tablet form, and probably the most popular brand name is Lyrica. Indications mainly include, in the States, Australia, Europe, and the UK, diabetic neuropathy and post-hepatic neuralgia. But it's also commonly used off-label for other pain disorders such as migraine, low back pain, and sciatica. And the reason for the increased use is probably the drive to avoid opioid analgesics. But there is a high risk of harm with pregabalin as well. So there are side effects: dizziness, somnolence, sleepiness, confusion. Patients have also reported an euphoric high at very high doses of pregabalin. And in a study of individuals who were recreational users of sedative and hypnotic drugs, a 500 milligram dose of pregabalin resulted in them saying that they had good drug effect, a high, and they liked it similar to a dose of 30 milligrams of diazepam. And this risk of misuse is particularly high in people with opioid misuse disorders, where pregabalin is used to potentiate the euphoric effect of an opioid and also to counteract withdrawal effects. Often you will see that pregabalin is used with opioids and with benzodiazepines, and in 2019 it was reclassified as a Class C substance and a Schedule III drug in the UK, which means that prescription needs to be very, very careful, and repeat prescriptions are not allowed. You can only provide up to 28 days of therapy. So again, as for opioids, careful consideration and vigilance is needed when you're making prescribing decisions about pregabalin. So moving on to the main topic of laboratory testing for opioids and pregabalin. Why would you want to test, and which drugs would you want to test for? So are you testing so that you can tell whether a patient is compliant with their prescription, that they're adhering to their opiate agonist treatment? If you know that you've prescribed someone an opioid, then do you need to monitor whether they're taking it? If you've got a cancer patient who's using it intermittently for pain relief, if they've been prescribed morphine, for example, for pain relief, then do you need to monitor that they're taking their morphine? I would say that's probably not an indication for testing compliance. Do you suspect that there is misuse? Are they misusing the drug that you have prescribed them, or are they misusing a drug that they've obtained in some other way? There may be a need to measure their urine drug in that sort of circumstance, or are you just measuring for profit because you know that you can charge someone for a test and that provides lots of revenue for your laboratories? There are so many tests available, particularly point of care for drug testing. There are automated analyzer tests available, and obviously at the higher end there's mass spectrometry, but you really need to consider why you might want to measure someone's drug level and whether you want to measure that in urine or another matrix. So which matrix is available? You can test in blood, but that's usually a forensic lab that would test in blood. Hair is also usually a forensic sample. We wouldn't generally use hair as a matrix in the clinical lab. Urine is our main matrix in Leeds, although we have in the past offered oral fluid analysis, mainly for patients who are on rehabilitation programs and receiving OAT therapy. But whatever sample you accept and analyze, you need to consider how you will confirm sample integrity. So for a urine sample, it's important that you measure creatinine, you look at the quality of the sample. Does it smell funny? Is it very green in color? Could it be that it's been spiked with the methadone that someone's been prescribed? So it's very important to consider that also when you receive these samples. What type of test are you going to use? As I mentioned, there are point of care tests and laboratory tests that are immunoassays that are suitable for, sometimes suitable for screening for these drugs. And there's mass spectrometry-based tests, so either GC, LCMS, LCMS-MS, or time of flight for confirmation. And if you are providing analysis, then are you going to provide qualitative, positive, negative? If so, what's your threshold for saying something's positive? And if you're quantitating, then what's your limit of quantitation? What do you report? Are you going to measure metabolites? That could be very important if you want to confirm that someone's taking buprenorphine or taking methadone as prescribed. You want to measure the metabolites as well. So if they're taking methadone, you need to measure EDDP, and if they're taking buprenorphine, you need to measure norbuprenorphine to confirm that that sample has actually gone through their biological system, that they haven't just provided a urine sample that they've put the drug into to make you think that they're taking the medication when actually they've sold it to a mate down the road. You also need to know a little bit about the metabolites of opioids, particularly if you're offering an analytical service. So many 4,5-epoxymorphinians are actually metabolized to active metabolites, which have high potency at the mu receptor. And some metabolites are actually more potent than the parent drug. So codeine is a weak agonist, and 10% of codeine is metabolized to morphine, which is 100 times more potent at the mu receptor. Similarly, dihydrocodeine is a weak agonist, and that is metabolized to dihydromorphine, which is 100 times more potent at the mu receptor. Also, because these drugs are metabolized by cytochrome 2D6, then depending on the genetic makeup of that individual, they may be slow or rapid metabolizers of the drug. And so the clinical response is relatively unpredictable. There's no way of screening everybody to know what their cytochrome status is. And so you need to be aware that some individuals, if you've got two people on the same dose, then if they're a rapid metabolizer or a slow metabolizer, then their drug concentrations will be very different. There are also different detection intervals in different individuals, so that drug might be present in their urine for longer depending on whether they've taken it with food, whether they're chronic users, whether they've got different metabolic activity. The free hydroxyl groups are further metabolized by glucuronidation to make water-soluble metabolites that can be excreted by the kidney, and some of those glucuronides are also metabolically and active at the mu receptor. And in the main, opioid immunoassays actually utilize an antibody that's directed against morphine. So if you have an opioid immunoassay, a general immunoassay, then it will pick up heroin and its main metabolites, 6-MAM. It'll probably pick up thebaine, morphine, codeine, and morphine as a metabolite of codeine. It may, depending on the assay, pick up hydrocodone, hydromorphone, dihydrocodeine, dihydromorphone, oxymorphone, but it will not generally pick up buprenorphine or fentanyl or methadone or tramadol, etc. So if you're thinking of introducing an immunoassay, you need to know what the cross-reactivity is, and ideally you would want to know what the antibody is directed to. Buprenorphine immunoassays are out there, and they're mainly enzymatic antibody assays, the CEDIA assays. And so there are a couple of papers I found which are quite interesting that have evaluated the CEDIA buprenorphine assay by Thermo. I'm not picking on Thermo, there are other assays available, and I'm sure they're very similar in terms of their properties. And so this paper was published in 2015, and they highlight that intake of a therapeutic dose of codeine can yield a false positive CEDIA buprenorphine result. And in fact, the IFU for the kit actually states a positive result using the CEDIA buprenorphine assay indicates only the presence of buprenorphine or cross-reactant. So really, in the grand scheme of things, how useful is that going to be? Well, there is a way of getting around it, and this publication in the Annals of Clinical Biochemistry 2017 said, well, if you test your sample with the opiate immunoassay and the result is negative, and then you do a CEDIA buprenorphine immunoassay, then you may not need to confirm that sample by LC-MS-MS. You can be relatively confident that there is buprenorphine in that sample if it's negative by the opiate immunoassay. What about fentanyl immunoassays? Well, there are a few available, and this is a very recent paper published last year that evaluates two immunoassays that were used in a particular lab. So initially, they were using the DR1 assay from Thermo, which had a cutoff values. They could detect fentanyl at 2 micrograms per liter and norfentanyl at 10,000 micromoles per liter. And then they transferred to the FEN2 assay by Roche, which has a detection limit of 3.8 micromoles per liter for fentanyl and 5 micromoles per liter of norfentanyl in urine. And they tested all of the samples in their laboratory by LC-MS-MS also, and they picked all of the samples that were true negative, had fentanyl and no norfentanyl, no fentanyl present, results less than 2 micrograms per liter in their mass spec assay, and they still had false positives in both assays, and there were also false negatives, so samples with fentanyl and norfentanyl above the detection limit of the assays that were not detected as in the immunoassay, so gave a false negative effect. So you get false negatives and false positives. So an assay with lots of false negatives suggests that the IFU of the manufacturer is probably overstating what their sensitivity is. And they actually found by TOF analysis of the samples that the false positives may actually be due to the presence of risperidone in samples, which is interesting. They also did a very comprehensive analysis where they spiked urine samples with each of these fentanyl analogs. It's a big story in the press that there's a new fentanyl analog identified every month, or very frequently, that is just released and found in patients with overdose in the States. It's a big problem that people are illegally making fentanyl analogs and selling them. And so they wanted to see which of those analogs were detected by those two immunoassays. So quite interesting results in that paper. There are also immunoassays for Pregabalin, and actually this paper suggests that it's actually quite difficult to make antibodies to pregabalin because it has a relatively simple chemical structure. But the paper published here in 2021 suggests that serum assays are actually quite good for pregabalin, but the urine immunoassay suffers a lot from false positives. What about mass spectrometry? Well, if you design your method appropriately, then you can detect anything by mass spectrometry. You can detect all of the illegal drugs and analogues. You can detect the prescribable ones. You can detect thebaine, as long as you design your assay appropriately. And that's the tricky thing, really. So just a little schematic to remind everybody about mass spectrometry. So this is a schematic of what happens in a mass spectrometer. So you introduce your sample, and prior to that, you might want to do some chromatography or sample derivation. That gets ionized and then introduced to the first quadrupole, where the molecules are separated according to size and charge. They're then collided with gas in a fragmentation quadrupole, and then the third quadrupole, which is TMS, the TMS2, MS2, separates all of those fragments according to mass and charge, and then they're put through into the detector. And you have to be very cautious about isobaric interferences. So the way you investigate whether you've got isobaric interference is by selecting particular transitions and assessing which ones are specific for whatever molecule you're trying to measure. And you can use multiple reaction monitoring, where you monitor several transitions simultaneously, where each transition will look at the precursor mass and then the product fragment mass. And typically, for a good assay, you have one quantifier transition, which you use to report the quantitative values, and at least one qualifier transition, which confirms the identity, making sure that you are measuring what you're actually wanting to measure. So our assay in Leeds uses, these are some of the transitions that we use. So this is 286 is the mass of morphine. And also, if you look in detail, our mass spectrometer is an API 6500, and the resolution is about 1 Dalton. So anything that has a similar mass can't be resolved. So the molecular weight of norcodeine is 285.34 grams per mole, and the molecular weight for morphine is 285.3377. If you have a high-resolution mass spec, then you would possibly be able to resolve that, but our mass spec isn't of adequate resolution for that, so how do we get around that isobaric interference? So we selected a sample that was positive in our opiate immunoassay, and we spiked that with morphine to 800 milligrams per liter. So this is the spiked sample when we ran it in our chromatography at pH 6.8, and when we ran it in our chromatography with the mobile phase at pH 8.0, you can find that the ionization changes and the time at which the peak is eluted changes, and you can clearly see that the molecule that was, or the drug that was giving you the positive result in the morphine assay was actually norcodeine, a mass of 438, which eluted, a mass of 285, which eluted at 4.38 minutes, and then morphine, which eluted at 4.7. So you do need to be careful about your chromatography if you need to resolve isobaric substances. So this is the panel of tests that we offer in Leeds. Here I've shown what the detection time in urine is, where it's known. So for example, if someone is using heroin, then the unique metabolite 6-monoacetyl morphine is only present in the urine for up to 24 hours. And so patients using heroin, if they present their, if you receive their urine drug sample 2 days after they've used heroin, then you will not be able to detect the 6 mam in their urine. You also need to know that, or need to appreciate that for some drugs, if that drug is used chronically, then it's going to have a longer window of detection in their sample. We provide quantitative results, but it's important to recognize that there is a potential to overinterpret. So sometimes we'll get inquiries from the clinical team saying, well, so last week this value was much higher. Does that mean they're now using less? That is not the case, and so you have to be very careful to describe that the detection time can depend on, yes, it can depend on the dose they've taken and when they were taking it, but it also depends on the urine concentration, whether it's chronic use, whether it's frequent use, what the urine pH is, what other medications they're taking at the same time, what their individual differences in metabolism are, whether their renal or liver function has also deteriorated. Also, in terms of mass spectrometry assays, there's lots of labs in the UK that offer this, but there isn't really any standardization. So some laboratories will have an enzymatic step before introducing the urine to the HPLC to hydrolyze the glucuronides. And some assays, they may not fully appreciate the effect of isobaric interference. Also, if you have so samples from patients who are using a high amount or have spiked their urine sample, for example, spiked with buprenorphine, you might get a drug concentration that's above the top calibrator of your assay, and that can cause saturation of your detector and carry over into the next sample. So it's important to look at the chromatograms to check for that.
Time, doctor? Sorry, time?
Time, sorry. So I just wanted to highlight really that there is lack of standardization. And I'll leave you with my last slide, which is basically showing you the difference between time of flight and quantitative mass spectrometry. I'm sorry I haven't been able to describe that to you.
Okay. Thank you so much, Dr. Carys and Dr. Ahmed.
Dr. Carys, I actually have a question. Yeah. Do you have the mic? Oh, yeah, okay. You mentioned that you're using the targeted mass spectrometry. What about the non-targeted? Because in the addiction laboratory in Kuwait, we started using the non-targeted tandem mass spectrometry. Do you have any, did you ever consider it in your lab, or did you just choose the targeted one? Because we're having such a headache using the non-targeted one. So
in the main, we use the targeted, and if there's any doubt, if a patient has presented with complex case where they've used many drugs, or they've used, they're suspecting overdose of other prescription drugs, or for example, if you've got a 2-year-old who presents with hypoglycemia and there's a suspicion that they've been given some any drug, we don't know which drug they have been given that's caused the hypoglycemia, then we would refer the sample to the Birmingham clinical toxicology unit, and they would do the time of flight analysis for us. But not many labs in the UK are using time of flight routinely. In the main, it's used in forensic laboratories rather than clinical laboratories. I think it's growing, but it's so expensive that not many labs have been able to invest in that yet.
Okay, thank you.
I also have a question. In the top 10 drugs in the UK, I think propranolol was ranked number 4. Is there a reason?
Sorry, say
propranolol was ranked number 4, yeah, of the drugs that are abused. Is there a reason? Does it give a high? Why is it high in the UK?
Where have you had Where have you got that information?
In the slides, I remember it.
Oh, from the toxicity?
Yes.
I think that's more suspected overdose rather than misuse.
Oh, yeah. So it's an overdose because, but why propanolol? This is my question. Maybe it's widely used, maybe. We don't know.
No, I'm sorry, I don't know.
It's all right. Okay, thanks a lot, everyone. We will conclude with the...
Which one you prefer, time of flight or LCMSMS?
Well, if we had the technology, then I would love to have a time of flight mass spectrometer. I think it takes much longer to ensure that you're confident in the results for time of flight, because you need to know the integrity of your library, and you need to gain experience of using that library. And if you've got a 98% match for this fragment and a 60% match for another fragment, and is it this drug, is it something else that is isobaric, then it takes a long time to develop that expertise. And also it's quite difficult to get time of flight assay accredited. So if you know that the drugs of interest are likely to be a relatively small panel, then a targeted assay is probably a good assay to do. It's cheaper to do, and it can usually get you answers. But if you haven't got the answers from that, then it's worth doing a time of flight, particularly in pediatric poisoning cases or overdose, where you really don't know what the agent might be.
Okay, great. Thanks for Dr. Carys and Dr. Ahmed. We will proceed with the closing ceremony.
And now for the moment you've all been waiting for, the competition. A quick recap on the rules. There will be a QR code with questions on the screen. Make sure you write your name, because we had a few entries yesterday with no names that could have won. The first 3 to answer correctly will win the prize. So that we have 3 winners. Make sure you answer them. Make sure your name is on the submission. So the first question, which of the following is an example of indirect reference intervals? Utilizing patient results stored in the lab's database, a priori selection of members of the reference population, collecting 120 healthy individuals to determine 90% confidence intervals. Number 2, which of the following tests is commonly used for the diagnosis of multiple myeloma? Zinc, serum protein electrophoresis, or glucose? And our final question, what is Pregabalin used for? Treatment of epilepsy and anxiety, treatment of diabetes, or treatment of multiple myeloma? Okay, number 1, Abdul Tawab Yusuf. Congratulations. Our second winner, Ahmed Abdul Wahab. Congratulations. And number 3, Bashair Hamid. Congratulations. As we come to an end of this remarkable journey, I want to express my deepest gratitude to our speakers, committees, and anyone involved in this. And especially to our esteemed guests who waited till 5 p.m. on a Monday. Your dedication and hard work has not gone unforgotten. We hope you have a great time learning, networking, and socializing during the past 2 days. And thank you for making this event truly unforgettable. Don't forget, your certificates will be sent by email within a week. And finally, we'd like to thank our organizing committee for making this work. Thank you.